Hey, and welcome back to the Full Code Podcast. I am Ron Dees, nurse practitioner. Today, I want to do something a little different. I'd like to react to content from some of our friends over at Critical Care Now who do a fantastic job at providing not only critical and emergency medicine education, but give us things outside of the clinical medicine to think of. And in this case, Dr. Mallemat is talking about the concept of anchoring. So if you're not familiar, let's dive into it and he'll explain it for you.
Never look at the chart before you go to see your patients in emergency medicine. Welcome back to Crit day number 6, and today we're doing a practical tip, not on resuscitation or vasopressors or chest compressions, but something you should do when you go to see your patients. Something that I've noticed residents doing in the past few years is pre-reading a patient's chart. Because everything is digital these days, you can look up the patient who you're about to see, you can look at the chief complaint, the vital signs, and then look at past visits at that hospital and then the other hospitals. And before you know it, you have all the data that you need before you enter the room and say hello to that patient. But here's the thing, if you've already read about that patient before you walk in the room, you've already biased yourself. Let's say, for example, that patient is presenting with chest pain, and you notice in the chart that that patient has had a few previous presentations for chest pain. Well, that patient's gonna have a hard time convincing you that on that visit today, they're here for something different than they had presented for before, because looking at the chart, you're anchoring your diagnosis on all the other presentations before. And I think one of the beauties of emergency medicine is it's one of the last specialties where you can walk in the room of an undifferentiated patient and be able to figure out what exactly is causing that person's chief complaint. Pre-reading the chart completely ruins emergency medicine for me, because that is the last sacred place where a patient is completely undifferentiated, has completely no labels until you go and see and talk to that patient. I'll bet you that a few of you are saying that's a completely ineffective way to see patients, because if you have that information there, why wouldn't you use it? But I'm not saying don't use it. I'm simply saying just go see that patient first, get their story from them, untainted, unadulterated from anything else that everyone has ever opined about that patient, and then form your own conclusion, and then go look at the chart and see what other diagnostic tests have done. This is completely my opinion. I don't have any randomized controlled trials to stand on. I only know that there's cognitive biases that present in clinical medicine. But I want to hear what you have to say, so please leave me your opinion of what I just said in the comments below. And those are the reasons why I always say, never look at the chart before.
All right, so right off the jump, obviously we are intensive care providers. We are not emergency medicine providers. We do see patients in the emergency department, but that is often, if not always, after we've been given some sort of handoff by our emergency department provider. We generally have an idea of what their working diagnosis is at that point, and we've likely already gotten a little bit of a history about the patient. Now, the first point that is made in this video is about kind of cognitive biasing and how you can read things in the chart which will alter your perceptions of the patient, which is true. Now, in this example, we're talking about, let's say, chest pain, a patient that by description is a frequent flyer. So when you're reading this, you might say, oh, this person always comes in for chest pain. It's probably not real.
Stop the cap.
Now, my counter is, and this isn't a counter to what is said in this video, but it's my general rule of practice. There are certain things that you never, ever, ever rule out without doing the work.
Good job.
So what do I mean when I say that? It means that when a patient comes in for chest pain, or let's say in our case, we're seeing a patient either in the ICU or during a rapid response, or maybe it's a patient that you're seeing on the floor that has acute onset chest pain while you're seeing them. I am never going to say, oh, you're not having a heart attack. I'm going to do all the things that I need to do to ensure that that's not the case, unless there's some sort of confounding factor which would point me into a very sure direction that is not an acute coronary syndrome of some kind. Now, a lot of people are going to make the argument that you need to be extremely judicious with your use of resources, which is true. And some people will even make the argument that your clinical history and exam and abilities as a clinician should be sharp enough that you should be able to tell if a patient is having a heart attack or not without utilizing a troponin or a 12-lead EKG. Now, might there be some truth to that? Maybe, but I don't have x-ray vision. I can't emit radiation from my eyes and see what's going on in the patient. I can't put my hands on their chests, wrists, and feet and tell what the electrical activity of their heart is.
I don't think you have the facilities for that, big man.
There are some instances in which you want to be sure because there are diagnoses that you don't want to miss. One critical component of provider education are red flag diagnoses, i.e. diagnoses that you cannot miss, or referrals that must be made. You never want to make unfounded assumptions, especially when it could cost a patient their life. Now, how does the idea of anchoring affect us in the ICU? For this, I would point to the concept of trust but verify, whether that's what you've read in the chart or what someone's told you or what has been reported off to you by another colleague. Obviously, you want to trust what another qualified healthcare professional says, but you often want to evaluate the situation for yourself.
What is he doing?
He's beginning to believe.
As we all know, we all see situations through different eyes, and that's why it takes a team to get this job done. So we can also back this up a little bit to things that are not life-threatening diagnoses. A great example of this is how many of you have been told that a patient is a quote pain seeker, someone who is looking for pain medications or opiate narcotics. Now, is that a common occurrence? Absolutely it is. Does that mean every time we start to see those red flags that we don't need to thoroughly evaluate a patient? No, we need to check every time. There's a reason that the general rule of thumb is a patient's pain is what they say it is. It then becomes your job as a clinician to thoroughly assess that patient. And in the same way that's mentioned in this video, if we get too deep into their chart and we make some assumptions, we might not be able to hear the patient when they're telling us what's really going on. And then we send them on our way to continue this painful cycle. No pun intended. So conceptually, what can we take from this advice? Don't make assumptions about your patient. Your patient is more than just their medical record. They are a person that's sitting in front of you with real concerns, complaints, feelings, ailments, and disabilities. I can't encourage you all enough. Go on over to Critical Care now. They are a wealth of critical care and emergency medicine education, and there's just so much high value content over there. And not just in the realm of clinical medicine, but also concepts like this that can affect our ability to diagnose, assess, and treat patients appropriately. If you enjoyed this content or you thought it was helpful, leave us a comment below, hit that like button, hit that subscribe button to help us break through the algorithm. If you're interested in more of our full code merch, go over and check out on the store. I'm in the process of rebuilding some of the original shirt prints. So if you still want to get those, they are available and the Bonfire store is still live. If there's any content that you'd like us to talk about or react to, please send it on over, link it in the comments, send it via email to thefullcodepodcast@gmail.com. And again, thank you for all the support. It means the world. Catch you next time.